Okay. A very good morning to everyone. My patient is a 60 years old gentleman, farmer by occupation, resident of Pauta, comes with chief complaint of dysphagia for 1 month. Patient was apparently normal 1 month back when he noticed dysphagia for solid food with sensation of food being stuck in the lower chest, insidious in onset, initially requiring water along with solid food to facilitate the act of swallowing. Gradually, dysphagia progressed over 1 month, where in now he can consume only liquid diets. He gives history of regurgitation, especially after consuming solid or semi-solid food. He gives history of 10 kg of unintentional weight loss over last 1 month with an associated history of loss of appetite. He gives no history of odynophagia, halitosis, neck swelling, gurgling sound while swallowing, difficulty in initiating swallowing, dysarthria, nasal regurgitation, associated chest pain, postural modification to facilitate food, relation of temperature of food. There is no history of corrosive intake, no history of symptoms suggestive of long-standing gastroesophageal reflux disease, no history of hematemesis or melena, no history of cough with expectoration or recurrent upper respiratory tract infection, no history of coughing or choking after swallowing, no history of hoarseness of voice or stridor. There is no history of abdominal distension, jaundice, hemoptysis, bone pain, back pain, blackout, or seizures. There is no history of tuberculosis, stroke, diabetes mellitus, hypertension, asthma, or COPD in past. Family history is non-significant. Personal history, he consumes mixed diet, normal bowel and bladder habits, sleep is undisturbed. There is history of BD smoking for past 40 years, about 10 BD per day. He is a non-alcoholic. Coming up to my summary of my presentation, he's a 60 years old man with no comorbidities, with a chronic BD smoker, come with complaint of short duration, progressive dysphagia, initially for solid, later on progressed to liquid since 1 month, with associated significant loss of weight and appetite.
Yeah, go back to your first slide.
Yes, sir.
Okay, next. Okay. Next. Yeah, explain all the negative history which you have asked. What is the relevance? It's a good negative history, but for the sake of others, just explain.
Yes, sir. Sir, I asked one whether he was having difficulty in swallowing along associated with pain, but till there was not associated pain. Pain can be associated whenever there is some kind of esophagitis. It can be associated with fungal infection like candida, or it can be associated with gastroesophageal reflux, and the mucosa can get inflamed in that cases. No history of halitosis or neck swelling. Patients.
Can, can a patient with mechanical or functional dysphagia also have odynophagia?
Sir, in case of uh, in case of a long-standing GID, sir, in that case, stricture can form, sir. In that patients, sometimes this odynophagia can happen, sir. In those cases, it can present with mechanical dysphagia in that cases.
You were right in saying that whenever there is esophagitis, there will be dysphagia.
Yes.
Esophagitis, commonest cause will be gastroesophageal reflux disease. In the initial phases of the corrosive injury, there will be esophagitis. So that is why there is odynophagia.
Yes,
And
sir.
also, patients, especially with functional disorders like achalasia, when there is a lot of stasis, there can
Yes.
be stasis-induced esophagitis. And
Yes, sir.
that can cause odynophagia. And malignant dysphagia, usually there is no odynophagia, it is
Oh,
only dysphagia.
this way. Uh, there is no history of halitosis, neck swelling, or gurgling sound. I'm just ruling out any Zenker's diverticulum, sir. There is no difficulty initiating swallowing, dysarthria, or nasal irritation. Sometimes patient can have a neurological deficit. Post-stroke patient, they can have a difficulty in starting in swallowing. Chest pain or postural modification or relation of temperature to food. Sir, in this, I am just ruling out motility disorders of esophagus. Uh, there is no previous history of corrosive intake. Corrosive intake also leads to stricture formation, and that can also present as dysphagia. There is no history suggestive of long-standing GID that associate heartburn or any. There is no long history of heartburn in them. There is no history of hematemesis or melena. Sometimes, sir, the tumor can bleed, sir. In that case, the patient can present with hematemesis or melena. No, because of there is dysphagia, sir. The food can accumulate, and a patient can have recurrent cough, and there can be micro aspirations also in the lung, which can present as a recurrent upper respiratory tract infection. There is no history of coughing or choking. Here, I just want to rule out, since as per history, I'm suspecting it to be malignant dysphagia. Sometimes when patient have specifically liquid diet, sir, in those cases, if there is a associated tracheoesophageal fistula post having the meal specific liquid diets, patient can have a choking or coughing sensation. So I'm just ruling out that. There is no history of hoarseness of voice or stridor. I just want to rule out any involvement of rectal laryngeal nerve. And there is no history of abdominal distension, jaundice, hemoptysis, back pain, and blackouts. Sir, in this, I'm just ruling out any feature suggestive of metastasis in this case, sir.
So if a patient with malignant dysphagia has hematemesis or melena, what does it suggest?
Sir, there can be the tumor can bleed, sir. One can be there, sir. One thing. Sometimes
Which tumor you mentioned the differential diagnosis as CA esophagus, CA GE junction. I would add another one, a proximal gastric cancer, which is involving the GE junction. So these are the three possibilities. Out of these, which is the one which is more likely to be associated with hematemesis and melena?
Sir, the one involving the proximal cardiac region, sir, and extending to esophagus.
Yeah, so in general, cancers of the esophagus are less likely to bleed as compared to cancers of the stomach or the GE junction. So these are soft points that if you have a history of hematemesis and melena, then you are thinking more in terms of a GE junction or proximal gastric cancer rather than an esophageal cancer.
Yes, sir.
The metastatic history, this I have said earlier also, jaundice is not a symptom of liver metastasis. Jaundice occurs in presence of liver metastasis very late when almost the entire parenchyma is replaced by multiple bilateral metastasis, or if there are lymph nodes at the porta hepatis or in the hepatoduodenal ligament, say in a gastric cancer, which are causing biliary obstruction. So that is biliary. There are no specific symptoms of liver metastasis except just cancer, cachexia, anorexia, and weight loss, which can be there without liver metastasis also. Similarly, in chest metastasis, pleural effusion, malignant pleural effusion, the symptom is dyspnea on exertion, dull diffuse chest pain. Lung metastasis usually do not cause hemoptysis. It is only when the metastasis erodes into a bronchus that they will cause hemoptysis. So the commonest symptom of a pulmonary or pleural metastasis, in fact, a pulmonary metastasis initially would cause persistent dry cough. And later on, there will be hemoptysis. Similarly, for cranial or brain metastasis, seizures will occur very late. Initial symptoms will be new onset, recent onset, persistent severe headache associated with nausea and vomiting because of raised intracranial tension, and then leading on to convulsions or focal deficits. Okay. And if you are mentioning, you can also mention no history of any spontaneous fractures, which is one of the common manifestations of a bone metastasis. The patient has a trivial trauma like a fall in the bathroom and sustains a fracture. So these are the common symptoms of metastasis. One thing which is missing in your history is very good, very detailed, is the site of obstruction. Sometimes the patient can locate where he or she is feeling the food is getting stuck. Is it
Yes.
of any help? Does it guide you?
Sir, as such, there is a very poor correlation between the site of obstruction and patient giving history. But if a patient is giving history, for example, he is having history in initiating the swallowing or in the mid chest, then probably the obstruction will be distal to it.
Yeah, the obstruction cannot be proximal to where the patient says that the food is getting stuck. Suppose the patient points towards xiphi sternum, that I feel that the food is getting stuck here, then obviously the lesion cannot be in the cervical or the thoracic esophagus. But if the
Yes,
patient says the food is getting stuck, say in the lower neck or in the chest, the lesion can still be below that because there is a lot of food which is accumulating and then the patient is feeling it. So you were right that there is very poor correlation. Uh, but you should mention whether patient could tell you where the patient is feeling the food is getting stuck. That would
yes,
complete the
yes,
history. And as I said, yeah, go to your differential diagnosis. Whenever you have a patient with dysphagia and you think of mechanic, so the interpretation is that this is dysphagia, it is mechanical dysphagia, and most likely it is malignant dysphagia. That is how, at the end of the history, you should almost never give a diagnosis. You should give an interpretation. So, interpretation, for example, in a patient with jaundice could be that this is jaundice, this is obstructive jaundice, this is malignant surgical obstructive jaundice, and most likely causes CA gallbladder, something like that. Similarly, you could say this is GI bleed. I think it is because of portal hypertension, and I think it is because of non-cirrhotic portal hypertension, which, considering the age of the patient, is extrahepatic. Similarly, here, the best way to answer it would be that I feel this is dysphagia, which is probably malignant, and the site of tumor, I think, is either esophagus, GE junction. Now, what is the difference between CA GE junction and a proximal gastric cancer involving the GE junction?
Sir, according to Sievert's classification, sir, GE junction tumors can be divided into three types, sir. Type 1 and 2 will be treated as a esophageal cancer, sir. But type 3, if it is the epicenter is in the distal 2 centimeter below G junction and it is extending towards esophagus, then we'll treat it as a CA stomach, sir.
Yeah. So if the two words which you have to use when you say GE junction tumors, one is the Sievert classification, second is the epicenter. So epicenter of the tumor for being mentioned or being classified as a GE junction tumor has to be within uh,
1 centimeter above, sir, and 2
1
centimeter.
centimeter proximal and 5 centimeter distal to the. So suppose you have a large proximal gastric cancer of which the epicenter is beyond 5 centimeter, then it doesn't classify as a GE junction tumor, but it can still be involving the GE junction to cause dysphagia. So that will become a proximal gastric cancer. It's a semantic difference because even for type 3 Sievert tumor, the treatment is like a proximal gastric cancer, isn't it?
Yes.
It is only type 2 where there is controversy. Type 1 is treated like CA esophagus. Type 3 is treated like CA stomach. Type 2, there are different points of view.
Yes.
Okay, please proceed.
Ji, sir. Coming up to general physical examination, my patient is an averagely built and nourished, alert, conscious, cooperative, oriented to time, place, and person, lying comfortably on bed with performance status of ECOG 1, BMI of 23.3 kg per meter square. He's afebrile. His heart rate is 78 beats per minute. BP is 128 by 76 mm of Hg. Saturation at room air is 98%. Respiratory rate is 15 minutes. Breathing holding time is 30 seconds. There is no pallor, icterus, bilateral supraclavicular lymph nodes, neck nodes, clubbing cyanosis, pedal edema. There is no sign of dehydration were noticed. Oral cavity examination. Adequate mouth opening with poor dental hygiene with nicotine stained teeth present. There is no halitosis or mucosal lesions seen. Coming up to abdominal examination. Inspection. Abdomen is flat, umbilicus is central, midline and inverted. All quadrants move equally with respiration. There is no visible lump, scar, sinus, engorged veins, pulsation, peristalsis of cuff impulse. Bilateral renal angles are the no fullness is felt, and hernial orifice appears intact. On palpation, all inspectory findings are confirmed. There is no local rise of temperature tenderness noticed, no organomegaly, no palpable lump. Hernial orifice on examination are normal. Bilateral renal angle non-tender. On percussion, no free fluid. Liver dullness starts in a fifth intercostal space with liver span 13 centimeter in the right mid-clavicular line. Rest of the abdomen is tympanic. Auscultation, normal bowel sounds were heard. On DRE, sphincter tone is normal, no external abnormality noticed, normal fecal staining stool present, no nodules felt. Respiratory system examination. On inspection, trachea is in central position, bilateral chest movement is normal, there is no engorged or dilated veins noticed over the chest. On palpation, trachea again is in central position, bilateral chest movement equal, normal tactile vocal fremitus present. Percussion, resonant note present in bilateral lung fields. On auscultation, bilateral airity is equal with normal vesicular breath sounds heard. No decreased breath sound or added sounds were heard. Other systemic examinations, CNS and CFS examinations were normal.
And what normal findings you were expecting or you were looking for in a patient in whom your history diagnosis is malignant dysphagia?
Sir, first, I would like to see the performance status of the patient, and at the same time, I would like to see the hydration of the patient. And apart from that, I would also like to see specifically the neck examination I would like to do for the cervical lymph nodes and also the supraclavicle lymph nodes I would like to see. Specifically, sir, I would also like to see the chest respiratory system examination in thorough. And apart from that, abdominal examination also I would like to examine properly, specifically in the epigastric region, sir. So look for any if any palpable lump is there or not.
Yeah. So in the general physical examination, oral, as you did mention, that is important. Yes. The orodental hygiene, that is important from the management point of view. Nutritional status, pedal edema, signs of loss of fat, any signs of nutritional vitamin deficiencies in the oral cavity. In the abdomen, in addition to the lump, ascites, hepatomegaly, because if it is a adenocarcinoma of the GE junction or a proximal gastric cancer, you could have liver metastasis. In the perrectal examination, you did mention nodules, you said normal fecal staining, but it would be good to mention no melena. Whenever you are describing a normal examination also, you should mention what you were looking for and it was not there.
Okay, sir.
And another point that you did mention that on percussion, there is no free fluid present. As far as I'm concerned, it is okay. But some examiners still insist that you describe the findings. You don't give the interpretation. No free fluid present is an interpretation. But the findings are that the flanks are not dull. And if they are dull, then there is no shifting dullness. So some examiners still insist that you describe it as you would do in an MBBS level exam. There are a lot of problems with your slides. Go back to your some of the previous slides. You have used a lot of capitals. Alert, conscious, YC is capital, cooperative, YC is capital. Next slide. You don't write S, go back. You don't write O2 as O and 2. O2 is always a subscript. That is what we were taught in chemistry. Next slide.
Yes, sir.
Again, why all these are capital C, C. After a comma, no capital unless it is a proper noun. No halitosis, mucosal lesion. Next. Why there is a hyphen after inspection? It is not required. If you were writing it in the same line, then a hyphen is required. If you are writing in different lines, then just inspection is good enough. Next.
Okay, sir.
A lot of places you have put a full stop or a colon or semicolon after a sentence, but it is not there at other places. You should have uniformity of presentation. So after tenderness noticed, There is no need to put full stop. Nowhere else you have put a full stop. Next. So it is not only the content, the structure of presentation should also be good. Next.
Yes.
I'm very happy that you described the chest examination in detail. Again, when you say percussion resonant note, what you are looking for is that whether there is a dull note to indicate pleural effusion. So in addition to saying resonant note present, you should also have said that no dull note present at the lung basis. So I know that you are looking for pleural effusion.
Okay, sir.
Okay. So in these cases, as we discussed on the Monday morning clinic also, usually diagnosis is not a problem unless the patient is young. Suppose this patient was 30-year-old and suppose the history was of 6 months duration. Then what would be your interpretation?
Sir, in young patient with long duration and also whether it is intermittent or not, it can point towards a motility disorder, sir.
So based on history, how do you differentiate between mechanical dysphagia and dysphagia because of a motility disorder?
Sir, in mechanical dysphagia, sir, it can be associated with some malignancy or it can be associated with GID, sir. In case of malignancy, sir, the history will be short, sir. It will be progressive. And whereas if mechanical dysphagia associated with GID further resulting into stricture, the history will be long-standing, sir. And whereas in with the most motility disorders, the age will be young, sir, in them.
So you mean to say in mechanical dysphagia, you cannot have a long history?
We can have, sir, in case of long-standing GID, sir, where it can lead to stricture formation, sir. In those cases, patient can have a long history in them also, sir.
So
yes,
you
sir.
can have mechanical dysphagia because of benign conditions like corrosive stricture,
Corrosive
like
stricture also, sir.
GERD stricture,
Yes,
and other uncommon conditions, or you can have a malignant mechanical dysphagia.
yes, sir.
So long duration of history, you can use only to rule out malignancy. So if a patient comes to you with a history of dysphagia of 2 years, it is very, very unlikely that it is malignant dysphagia. But if a patient comes with a history of dysphagia of, say, 1 month, 2 months, 3 months, it can
Yes.
be anything. A patient with benign disorder also can present early, isn't it?
Yes, sir.
So long duration of history to a great extent excludes the diagnosis of malignant dysphagia. That is the importance of duration. Next.
Sir, age, sir, whether it is intermittent or progressive, sir, mostly this motility disorders will have an intermittent history, sir. The patient will be young, and it can be associated with the temperature of the food. It can aggravate the symptoms in them.
And as you mentioned, that some patients give you that history that by assuming different postures,
Yes, sir. Yes, sir.
they can help the swallowing process. So sometimes the patients come with that history. Some patients elevate their lip like this, and some patients tilt their trunk, and that can help relieve dysphagia to some extent. Also, in motility disorder, usually the dysphagia is for liquids because solids still go down because of their weight, because of gravity. So
Yes.
these are some of the differences between a mechanical and a motility disorder dysphagia. Can you have some history of intermittent dysphagia even in a mechanical obstruction? The patient says that 1 month ago I could not swallow anything, but then it improved and now I can swallow a little more. Okay. Is it possible?
Sir, in case of rings, specifically Sharkey rings, when patients sometimes have some meatballs or something, they can have a complete dysphagia, sir. And then patient it
Bolus, that is what is known as the food bolus impaction,
yes, sir.
especially with non-vegetarian food or very fibrous fruits, or even a seed can get stuck. Large seed can get stuck. So food bolus impaction can cause temporary worsening of dysphagia, which gets relieved on its own as the bolus dislodges and that history sometimes may be present even in patients with mechanical dysphagia.
Yes.
Also, as I mentioned, when you have stasis induced esophagitis because of the pain, the patient may not eat or may have difficulty in swallowing, but as the esophagitis settles either on its own or with some treatment, there may be improvement in dysphagia. But stasis esophagitis is more likely to happen in motility disorders, especially in achalasia, where the esophagus dilates and a lot of food accumulates proximal to the site of functional obstruction rather than in mechanical. Dilatation is less common or less severe in mechanical dysphagia as compared to functional. Proximal to a corrosive stricture, there will be dilatation, but not as much as you would see in a achalasia. That is why megaesophagus, sigmoid esophagus, they are more frequently seen in achalasia rather than in corrosive or malignant dysphagia.
Yes.
Okay. So this patient comes to you in the OPD. What will you do?
Sir, first of all, I will just counsel the patient and his attendant about what I'm thinking, and then I'll do some investigations. First, to see the fitness of the patient and to diagnose, to confirm my diagnosis. I would like to get some routine blood set of investigation, and I would like to also offer an ultrasound abdomen as an extension of my clinical examination, and also get an upper GI endoscopy, sir, for the patient.
Why ultrasound?
Sir, I'm thinking in terms of, sir, it can be a carcinoma G junction tumor, sir. In those cases, an ultrasound can help to see if there is any swell in the liver, or if there is any ascites, or any lymph node specifically around the celiac axis. Uh, any if it can be picked up, any nodules over the omentoperitoneum, if it can be picked up. So these all things can have to tell a patient can have an M1 disease in that case.
Yeah, so in a patient with dysphagia, especially malignant dysphagia, there are two approaches. You will have some teachers or examiners who will prefer an upper GI endoscopy first because that gives you an opportunity to confirm the diagnosis and to get a tissue diagnosis. On the other hand, personally, I have no objection if you say an ultrasound first because it is a non-invasive investigation, and especially if, as you rightly mentioned, it is a CAG junction adenocarcinoma or a proximal gastric cancer which is causing dysphagia, you can have liver metastasis. And if you see liver metastasis and prove them to be metastatic by fine needle aspiration cytology, then you can say that when I am doing an endoscopy, at the same time, I may think of a endoscopic intervention in the form of placing a stent rather than first doing an endoscopy, then doing an ultrasound. So I mean, as far as I'm concerned, I'm willing to accept that also. But otherwise, by and large, when you are dealing with a possible hepatobiliary pancreatic malignancy, ultrasound has to be mentioned as the first investigation because there, if it shows a metastasis, in most cases, you will not proceed further. On the other hand, if it is a GI malignancy, esophagus, stomach, colorectal, then an endoscopy and biopsy is usually the first investigation because even if ultrasound shows metastasis, except in esophagus, most other cases you may still go ahead with surgical, definitely in colorectal, but some people feel in stomach also in a good risk patient. So, as I said, I personally have no objection if you mention ultrasound as the first investigation, but by and large, endoscopy and biopsy.
Yes.
You said some routine blood investigations. What do you mean by routine blood investigations? I think all of you should avoid using this term. You should specifically say what blood investigations you want.
I'll get an CBC, sir, and LFT, and RFT, and electrolyte, and at least these I will get it done, sir.
Why LFT?
So as to look for specifically albumin levels of the patient, sir.
So then it is not LFT, then it is assessment of the nutritional status. The rest of the LFT is not of much use in a patient with a upper GI malignancy, isn't it? So it's mainly to assess the nutritional status of the patient.
Yes, sir.
Okay. So we have the findings of these tests and yes.
So his hemoglobin was 12.1, sir. More or less all of the reports biochemical parameters were within the normal limits, sir. And then next investigation,
And say that
yes, sir.
nutritional status is reasonably okay. 3.5
Yes, sir.
is okay, not bad.
Fine, sir. We got an upper GI endoscopy also, sir. There it shows an ulcerative proliferative mass lesion seen from 35 centimeters to 40 centimeters. G junction is located at 40 centimeters, no varices. Biopsy was taken from the mass and sent for histopathological examination. Rest the fundus, corpus, tantrum, and pylorus of the stomach all were normal, sir, and even in D2 was also normal. In upper GI endoscopy, they made an impression of query CA esophagus at G junction, Sievert's type 1, they said, sir.
So on endoscopy alone, can you say that it is a Sievert type 1, type 2, or type 3?
Sir, depending upon the legend, sir, from the G junction, then we can classify, sir, into Sievert's 1, 2, and 3, sir.
Sievert classification is for what tumors?
Sir, for G junction tumors, they're further divided into 3 types. Type 1 is depending from the G junction tumor from 1 centimeter to 5 centimeter above the G junction. Type 2 is 1 centimeter above and 2 centimeter below the G junction. And type 3 is 2 to 5 centimeter below the G junction tumor, sir.
So does it apply to all histological types of esophageal?
For adenocarcinoma,
that is what I was saying, that unless you have the histology, because suppose the histology comes as squamous cell carcinoma, then Sievert's classification doesn't apply. Sievert's classification is only for the adenocarcinoma of the G junction. Yes. Okay. Next.
So we got the histopathological report, sir. It turned out to be a moderately differentiated adenocarcinoma.
Okay.
This was the X-ray.
Is it possible to classify a G junction tumor as type 1, type 2, or type 3 on endoscopy in all cases?
In all cases, it won't be possible, sir.
Why? What is the
sometimes sometimes the mass is so big, sir, that the scope cannot be passed beyond the
mass. You have to be able to pass the growth. Unless you pass the growth, how would you know where the epicenter is, isn't it?
Yes, sir. Yes.
So you have to be able to visualize the entire growth. That is why if the tumor is not passable on endoscopy, you cannot classify. Then how do you classify if it is not passable?
We can get an CCT, contrast in a CT, sir, and we can, according to that, we can assess where the
Why not a barium? Why not a barium?
Barium can also tell, sir, the upper the area of narrowing and upper margin, sir, where the.
In this case, now after this endoscopy and biopsy, would you do a barium?
Sir, already the patient has been proven to be in malignancy, sir, and I will be going further to do and contrast in a CT, neck, chest, and thorax, sir, with oral.
Yeah, so that is the reason that although barium tells you these two information, that it tells you the length of the lesion, it tells you the proximal and distal extent of the lesion, which you may not be able to see if the tumor is not passable on endoscopy. And therefore, it classifies an adenocarcinoma of the GE junction into Sievert 1, 2, or 3. But most people today, or most groups today, would not do a barium in a patient with malignant dysphagia, because in any case, you are going to do a CT with oral contrast, which will give you all the information which you require or which you get from a barium. So that is why for malignant dysphagia, barium is usually not done. On the other hand, if you are dealing with a corrosive stricture, many endoscopists still would want a barium or a gastrographin study before they do an endoscopy to have it as a roadmap. Because in corrosive stricture, there is not only narrowing, there is also deviation of the axis. And that can be dangerous because it can result in a perforation. So they want to know the tightness, the length, and more importantly, the axis of the esophagus and the stricture before they attempt an endoscopy or an endoscopic intervention. So that is one situation. Second is, in motility disorders, sometimes barium gives more information than endoscopy, because in the early stages of a motility disorder, endoscopy may be apparently normal. There is only some resistance to the passage of scope, which can be appreciated only by an experienced endoscopist. Whereas barium, especially if it is done as a fluoroscopic study, dynamic study, will show you the peristalsis, the contractions, and the stasis, which will help you to diagnose early stages of a motility disorder.
Yes.
Next.
Sir, this is the chest X-ray, sir, of the same patient. And also the ultrasound report.
No, don't describe. If you show an image, you have to describe it.
Sir, this is in chest X-ray showing PA view. As such, the lung fields are totally clear, sir. There is no space occupying lesion visible on the chest X-ray. There are some hilar prominences are there, sir. And the claustrophrenic angle is completely clear, sir, in them. No evidence of any fusion.
So in the lungs, do you call them space occupying lesion? You don't call them space occupying lesion. You call them pulmonary nodules. So there are no nodules, as solitary or multiple nodules, and the claustrophrenic angles are clear, indicating that there is no pleural effusion. You should specify that.
Yes.
And what else do you look for in a chest X-ray in a patient with dysphagia?
We will look for, sir, the trachea, sir. Is there any deviation or not?
Why should there be deviation of trachea in a dysphagia patient?
Sometimes, sir, esophageal cancer, sir, specifically near carina, it can involve trachea and.
That will not cause deviation. That will cause only chinking. So you can see chinking of the lumen. That is okay. There will be no deviation. You can say that the other important thing, not in malignant, but especially in patients with motility disorder, is evidence of aspiration pneumonitis, which will show as patchy consolidation, especially at the bases, which is different from the nodules. Pulmonary nodules indicate metastasis.
Yes.
But aspiration pneumonitis means parenchymal opacification, patchy consolidation, especially at the bases. So these are all the things. And of course, in a patient where you are suspecting achalasia, a hugely dilated esophagus can produce a soft tissue shadow, causing mediastinal widening, which sometimes you can even see an air fluid level inside it.
Yes.
And you can also comment on the fundic air, especially in patient with corrosive stricture or a peptic stricture. You may not find any air in the fundus. Also, when you see a good fundus air bubble, you can see a soft tissue impression of a tumor at the GE junction or a proximal gastric cancer, which is causing a soft tissue filling defect in the gastric air bubble. Okay, next.
This was the ultrasound report, sir. It shows liver normal with simple cyst noted in right lobe of the liver. Gallbladder has multiple calculi with normal wall thickness. CBD and portal vein caliber normal. Rest all the organs it will normal, and they advise endoscopically in them. Sir, I got an contrast in an CT, sir, with IV neural from neck, thorax, and abdomen, sir. This is the plain film, sir. Should I play, sir?
Yeah.
Sir, this is the trachea which is going, sir. Here we can see at back, just in front of vertebra, there is a radiosens shadow. That is the esophagus, sir. Once we track it down, sir, we can see the aorta coming into the picture, sir. And this is the tracheal bifurcation, sir, into the right and left bronchus. Here we can see as such the planes between the trachea and esophagus is here, sir, but the right bronchus it appears to be abutting it. And once we follow it down, sir, here we see 1 minute, sir. No, no.
Okay, let it play. Let it play.
Yes, sir. Yes, sir. Here we can see there is a irregular lumen at the G junction, sir, which is extending up to the cardiac region, sir. Thickening of the wall of the and once we follow it down, sir, here in gallbladder also we can see radiodense calculi and a simple cyst in the right lobe of the liver, sir. Rest contrast enhanced CT also have got it done, sir. This is the IV contrast enhanced CT. It shows same here, sir. The trachea is going down, sir, and this is the esophagus and the aorta. As such, the planes between the esophagus and aorta appears to be preserved, sir. And just at the bifurcation of the right bronchus, sir, there appears to be narrowing, and the planes between the right bronchus and the esophagus appears to be abutting, and once we track down, sir, again.
Right or left? Which
Sir, left, sir,
bronchus
sorry. Left.
is more close to esophagus? It is
Left, sir.
always the left.
Left, sir. Yes, sir.
So you have to remember that it is not only supracarinal lesions, even immediate infracarinal lesions can have involvement of the left bronchus.
Left, no. Yes, sir.
Although the trachea and carina are free.
Yes, sir. Again, sir, once we follow it down, sir, we can see an irregular thickening coming into the wall of the esophagus. It is going till the cardia, sir. And as such, no lymph nodes I am able to appreciate near the celiac axis, sir, and rest same findings, sir.
So in a lesion like this, what is more important, the proximal extent of involvement or the distal extent of involvement?
Sir, distal extent of involvement is more important, sir.
Why?
Sir, because according to that,
mentioned, which is unfortunately not mentioned by most endoscopists.
yes,
So what is your interpretation of the CT scan?
sir, this is sir, this is a G junction tumor, sir. It appears, and the planes are preserved, sir, as such on between the and it appears to be an resectable lesion, sir.
Type? Sievert type?
Sievert type 2, sir.
Sievert type 2, because the epicenter seems to be within 1 centimeter above and 2 centimeter below the
Yes.
G junction.
Yes.
It is neither going up into the esophagus nor going down into the stomach. So most likely it is a type 2.
Yes.
It is advanced. It is not an early esophageal or G junction cancer, but it is possibly resectable. Why do you say it is possibly resectable? What were you looking for?
Sir,
Yes.
I was looking, sir. Yes, sir.
Yeah. So what were you looking for to decide the resectability?
Sir, I was looking at the planes, sir. First, since it is G junction tumor, sir, I was looking whether the planes between the aorta and the esophagus is maintained or not. Also near the carina, also I was just looking whether there is some involvement or not. And also I was looking for the lymph nodes into the abdomen, around celiac axis and beyond, whether they are also involved or not. So, and also I was also looking for the uh, liver, any peritoneal nodules or any omental nodules which were appreciated or not, any as well in the liver, any ascites. This appears to be locally advanced as such and possibly resective.
Yeah. So one is, of course, distant metastasis, which do not make the tumor technically unresectable, but you would not like to resect because of the poor outcome.
Yes.
The unresectability per se is because of the local infiltration, for which the three important structures are
Aorta, sir, trachea, sir,
and third,
uh, uh,
what makes it T4B?
sir,
T4B is
vertebra, sir, vertebra, aorta, and trachea, sir.
vertebra or the posterior mediastinum.
Yes.
So, tracheobronchial tree, aorta, and as Dr. Vihar Kotecha says, that here the tumor, as you rightly said, is in the lower esophagus. It is a GE junction tumor. It is not going up to the carina.
Yes.
So, because at the level of the carina or the left bronchus, there is no tumor. It is
Yes.
only the esophagus. And the abutment is because of the low BMI, there is no fat, or maybe there is some amount of dilatation. So it is not there. And therefore, in a GE junction tumor, it is mainly the aorta and the vertebra or the posterior mediastinum.
Yes,
And
sir.
what structures, even if they are involved, do not make it unresectable? They may be involved, which make it T4, but it doesn't indicate unresectability.
Sir, it can be pleura, sir. It can be pericardium, azygous vein. These.
And so three structures in T4A and three structures in T4B: pleura, pericardium, and crus of the diaphragm.
Plus of the diet. Yes.
Okay.
Yes.
You should comment on those in the CT, but they don't change your plan of management because they can be resected. Whereas involvement of the tracheobronchial tree, aorta, and the vertebrae or the posterior mediastinum make it unresectable. And although you did mention about abdominal node, but as Dr. Kotecha pointed out, you should have mentioned about the thoracic nodes also, the paraesophageal subcarinal nodes,
Yes.
which again do not make it unresectable, but may change your plan of management.
Yes, sir.
So I think we are already at 10. I think we will anything else you want to show? Any other investigation quickly?
No, sir. It was just the CT scan report that I got, and then it was finished, sir.
So is there any other investigation which some groups may do and some guidelines probably now include in the management of CA esophagus?
Sir, PET CT scan, they mentioned, sir.
Yeah, I think if I remember correctly, the recent NCCN guidelines do mention PET scan. Check on that to confirm this. And PET probably has been recommended as a routine now to look for distant metastasis, number one. And number two, if they are not there, but the tumor is locally advanced or node positive, and if you're going to give neoadjuvant treatment, to assess the response, the biological response
Yes.
of neoadjuvant treatment, also PET scan is recommended. And then, of course, is the discussion about neoadjuvant treatment and upfront surgery and what surgery. So if you want, maybe you can carry forward this discussion on the management of this patient. Inform Dr. Anand if you would like to do that, then he will give you a slot for presenting the management. You can do a brief review of management of adenocarcinomas of the GE junction, type 1, type 2, type 3. As I said, 1 and 3 are clear. Type 2 is the debatable one, which we can then discuss. Okay.
Yes.
Good. Any students, any attendants online would like to ask or say anything? So all the attendants, please send me a mail, vkkapoor.india@gmail.com. Write esophagus in the subject of the mail. So I will be happy to send you the chapter on esophagus from my online book, Pearls in Operative Surgery, which will discuss a little more issues in more detail. Okay. Thank you, Pawan. Thank you.
Thank you, sir. Thank you, sir.